excellent.
All right, iGel's going in.
And we'll pause for a pulse check. Okay, so let's charge both those.
First,
All right, good CPR.
Charge the other one as well.
We'll swap you in just a few seconds.
Just do a pulse and rhythm check. So the patient's still in course VF. So let's do dual-sequential defibrillation.
Okay.
That's on you, okay?
Yeah, you do both.
How are you guys feeling? You guys feeling good?
Yeah.
Cool.
Okay, gang, are we all ready? Yeah, perfect. Okay, so I'm just going to share some of the clinical information for the case. So this patient, his name is Mr. Brown. He's a 54-year-old man, and he was brought in with the chief complaint of chest pain. So the triage note says that he was playing his usual weekend hockey game, and chest pain started during the game about 2 hours ago. He noted that while he was playing a bit more intensely, the pain intensified, so when he rested it got a bit better, but it's been consistently present since he arrived to the emergency department. His vital signs at triage were essentially normal. Heart rate was 80, blood pressure is 110 on 60, respiratory rate 16, oxygen saturation 99% on room air, and his GCS is 15, and he's afebrile.
All right, great. So guys, why don't we get started? Why don't we hook the patient up to monitors, get a full set of vitals, including the temperature and glucose. If we could get 2 large bore IVs inserted as well, and call for a stat 12 lead ECG and get a full panel of blood work, a cardiac panel including a troponin. That'd be great. And then Joanna, maybe you can start with the primary surgery.
Sure.
Mr. Brown, I'm just gonna get you changed. Just like your
Hi, Mr. Brown. I'm Dr. Yu. There's going to be a lot of stuff going on here with people poking you for IVs and hooking you up to monitors, but if it's okay with you, I'd like to sit down and just ask you a few questions about what's been going on.
Sure, Dr. Yu.
Yeah, so tell me what brought you into the hospital today.
I just started having this chest pain while I was playing hockey about 2 hours ago.
Okay. And have you ever had chest pain like that before?
I've never had chest pain before.
Never. Okay. Do you have any other past medical conditions that I should be aware of?
Not that I'm aware of, no.
Okay. And are you on any medications at all?
Right there.
No medications that I take regularly.
Okay. Is there anyone in your immediate family, like mother, father, brother, or sister, who have heart disease or blood clots to their lungs?
No.
No. Okay. Okay. And what does this chest pain feel like?
It's really intense. Like it feels like a pressure on the center of my chest. It's just the middle around the sternum. It's about a 6 out of 10, and it's been constant.
Okay. Anna, can we actually give the patient ASA 160 milligrams and 2 sprays of nitroglycerin underneath the tongue? Okay. Well, you know, we're going to give you some medications to see if that helps. Is there?
I'm feeling really dizzy, Doc.
Oh, okay.
I don't know.
You feel like you're going to faint?
20 gauge.
Mr. Brown, are you still there with me?
IV 20 gauge for
Brown?
ACF.
I can't feel a radial pulse.
Okay, patient's pulseless. Let's start CPR.
Grab me the backboard. Okay, let's roll him over.
Can you just get him the step stool?
Yep. Here you go, Jeremy.
Oh,
Do we
right
have him on the monitor?
Step stool's right here.
All right,
We got him here.
Here you go.
Okay, we're gonna roll him over to apply the backboard.
Yeah, and then maybe we can just get the defib pads so that
Yeah,
when we roll them,
absolutely.
we'll get board and pads under at the same time. So we'll just continue that.
Okay.
Looks like the
CPR,
patient,
Jeremy.
Yeah. So Joanna, if you could
Yeah.
just monitor the CPR and just make sure that you're rotating providers.
Okay.
Are we able to put the backboard in the patient?
Yes.
Okay, off
ready?
the chest.
David,
go.
are you able to tell me when CPR has been ongoing for 2 minutes?
Yep.
4,
Okay.
5, 6,
Good.
7,
Roll back.
8.
Excellent. Continue on.
Okay.
So David, can you just let me know
And then,
every 2
Cindy,
minutes
do you think
when,
we'd be able to get the
it's-
patient
we're
on some
stopping for a
oxygen?
pulse and rhythm
I
check?
can do that.
Okay,
Come on the
excellent.
other side.
So patients in pulseless VTAC, we're in the pulseless VTAC algorithm, guys.
Okay, do you want
So
a bag
as soon
and
as we
I'll
have
work on
that
going to
charged
get
and
an
ready to
eye
go,
gel?
let's shock them and continue CPR, okay?
All right,
So
we have
continue.
defib on the monitor.
So continue doing CPR
Okay.
while we charge that.
Okay,
Good
cardiac
CPR,
to
Jeremy.
200.
Excellent.
Okay, clear.
Okay, let's clear and shock.
Shock delivered.
Okay, continue CPR.
Okay, I'm just
What meds would you like me to prep?
Let's get the epinephrine prepped and ready to go. We're not going to do that unless we actually have to give 2 shots. So,
45 seconds to pulse check.
okay, excellent.
Okay, and then who's going to do CPR after Jeremy?
I will.
Okay.
Anna,
So
can you
Erica, do
grab
you want to
an
line
IV?
up
You can have
after
an
Jeremy at the time we do the pulse
Cindy,
check?
you're going to give 2 breaths every 30 seconds, every
done?
compressions. Perfect.
Do you need?
Okay. Supplies ready for you, Jeremy.
Okay.
So continue CPR.
Keep doing CPR?
And Cindy, Joanna, can you
Yep.
actually prep an iGel LMA?
I have an
Oh, you
iGel.
have an
Yep.
iGel? Okay. So whenever you're ready, maybe you can just insert that so that we can switch to continuous chest
Okay,
compressions.
perfect. All right. And then, Erica, if you want to get ready to do CPR after Jeremy.
Jeremy's gonna do the IB.
5 seconds to
breaths.
pulse check.
All right, Cindy, what we'll do is I'll plan to put the eye gel in.
Can
so
you get that charged and
we're
ready to
in
go
between
case the
rests, I'll
patient's
put it in right
still,
now.
in cardiac arrest?
Okay, charging to 200.
Excellent.
All right, eye gel's going
And
in.
we'll
monitor's
pause
turn.
for a pulse check. Oh,
Yeah,
I have
eye gel's
I have a
in.
pulse, so you can
Alright,
just turn that
excellent.
off. So it looks like the patient's in normal sinus rhythm. Can we call for a 12-lead ECG?
Can I get a 12 lead ECG stat to the trauma room?
Do we have
12
IV
ECG stat
access
to the
right
trauma
now?
room.
Yes, we do.
20
We have
over
a
here.
20 gauge IV to the left.
We also
So
have
a 12 lead
N-title
ECG is now available for you to review.
Okay, thank you very much. Okay, so it looks like the patient has ST elevations in leads 2, 3, AVF. So I'm concerned that the patient has an inferior STEMI. Are we able to get right-sided and posterior leads as well?
The ECG tech will be back in a few minutes.
Okay, so we'll get right-sided posterior leads when they're ready. But let's call activate code STEMI and activate the cath lab.
Blood pressure
Yeah,
87
yep,
over
this map
46 with a VAP of 59.
Okay. And given that the IGEL LMA is, we should ask the cardiologist if they want us to give another antiplatelet agent as well, like clopidogrel or ticagrelor. And can we also give him heparin 5,000 units IV as well?
Jeff, there was a rhythm change.
So I don't have a pulse. Looks like the patient's in a course VF. So let's start CPR.
Okay.
So we're gonna do
Monitor
continuous
charging to
CPR now.
200.
Yeah,
All right,
you can.
David, can you let me know in 2 minutes again to change
Okay, so
to
we're
change
in
compressors?
V-fib.
Okay, let's clear.
Clear chest.
Shock. Yeah.
Shock delivered.
Perfect. Continue CPR.
Can we lower the bed a little bit?
Yeah.
Lower the bed. Okay, so Dave, just let me know every 2 minutes for a pulse and rhythm check.
that
That'd be
good?
great. Do that.
I do have N-title in line.
Okay.
Excellent.
So the end-tidal CO2 isn't reading right now. Are we sure that it's hooked up to the monitor?
Yes.
Okay. Okay, it's not reading just yet, but we'll just continue on. Doing great CPR. Good job, Erica. Let me know if you get tired at any point, and we'll swap out.
Okay, and then Jeremy, you're gonna be in line after Erica? Okay.
Okay, perfect. So guys, we're in the pulseless VF algorithm, presumably secondary to an acute inferior STEMI. So have we already given the heparin?
Heparin's given.
So heparin's given, ASA's already been given, and we don't have an OG, so we can't give a second antiplatelet agent. Is cath lab aware of this patient as well?
Cath lab is aware, they have someone on the table, they should be able to take him in about 15 minutes.
Okay, perfect.
Journey, I'm getting tired.
Okay, so we'll, how long until?
45 seconds to the next pulse
Okay,
check.
maybe we'll just swap out now.
Yep,
If you're
okay,
tired.
all right. Okay, who's
Excellent.
gonna do CPR after Jeremy?
Shall we switch, Anna?
Okay, excellent. So we have epinephrine ready to go as well.
Yes.
Okay, so we'll get that ready. If the patient needs another shock, then we'll start giving him epinephrine after that.
Okay.
And how long until the pulse check?
15 seconds to the next
15
pulse
seconds?
check.
Okay, so let's just charge and get that
Charging
ready.
to 200. Okay.
Okay, we'll pause for pulse and rhythm check.
Okay,
Patient's still in VF shock.
Okay.
Clear?
everybody clear?
Okay. Shock delivered.
Okay, back on the chest.
And that's our third shock.
Excellent. Can we
Second.
give 1 milligram of epinephrine IV?
1 milligram of epinephrine IV given, Dave.
1 milligram epinephrine IV given.
Thank
Thank
you.
you.
Okay, so we've given epinephrine, we've given now 1 shock for the VF, right? Does anyone have any other questions or suggestions that we should be considering right now?
Can we give any other antiarrhythmic?
Yes, that's a good point. Why don't we give amiodarone 300 milligrams IV? Thanks for that suggestion.
Okay, and we could consider dual-sequential defibrillation if we're unable to get him out of it.
Okay, so why don't we try
Amiodarone,
one more
300 milligrams given.
defibrillation at 200 joules, and if the patient's still in course VF, at this next pulse and rhythm check, let's get other pads set up,
Okay.
and we'll do a dual sequential defibrillation. Is that cool?
And then Anna, do you want to get ready to do CPR after Jeremy's done?
1 minute to the next pulse check.
Okay.
Okay.
And then,
So on
Grab the
1
pads.
minute, you guys will swap out for CPR if that's cool.
okay. And then Erica, for the pads, should we do, so he's already AP.
He's already AP, so whether we can do material.
Perfect, yeah.
Perfect. How are you feeling right now, Jared?
I'm okay.
Yeah, you're feeling okay? So the end-tidal CO2 is reading at 16. Is he easy to bend right now?
He's easy to beg.
Okay. And hey, Joanna,
Yes.
maybe you could actually bring a bedside ultrasound and just have a look at what the heart's doing, because I just wouldn't want to miss like a massive PE or a tension pneumothorax.
Okay, somebody's going to grab the ultrasound.
Okay, excellent. Thank you so much.
10 seconds to the next pulse
Okay,
check.
so let's charge that and get ready to shock.
Okay, charging to 200.
Yep. Charge. Okay, let's pause for a pulse and rhythm check. Patient's still pulseless. So guys, let's clear and let's just give him another shot.
Okay, clear. Shock delivered.
Okay, excellent.
Second
Continue
set
on
of pads
CPR.
on.
So for meds, he's gotten so far 1 of epi and 100 and 300 of amiodarone.
And ASA.
And
Yeah.
ASA.
And Dave, where are we on the epi? Has it been 3 minutes since the last epi yet?
2 minutes since the last epi.
Okay.
So I'll let
Anna,
you know
can
in
you
10
get
minutes.
ready to?
10 seconds,
oh,
Dave.
you're going to be shocking, right? Erica, do you mind coming in over here to swap out with Jared?
Absolutely.
Okay, excellent.
And then Jeff, I was just going to leave the eye gel in until we get Rosk.
That's perfect. Yeah, I think that's
He's
totally
begging
appropriate. Oh, why are you charging? Yeah. So we have 2 sets of pads on right now. They're placed correctly. So one is lateral, one is anterior posterior.
When we're ready for the next pulse check.
Excellent. And how long until epi?
It's been 2 minutes 45 seconds since the last dose.
So
of
why don't
epi.
you give him another milligram of epinephrine?
Okay. 1 milligram of IV epinephrine given, Dave.
1 milligram IV epinephrine given.
All right, and I'm ready at ultrasound for the next pulse check.
Okay.
1 minute to the next pulse check.
1 minute. Okay, excellent. So guys, we've already given 2 shocks in VF. It seems like he's in refractory VF despite defibrillations and amiodarone. So the plan at the next pulse check is if he's still in cardiac arrest and still in course VF, we'll do a dual-sequential defibrillation. So we'll charge both of those machines and get it ready for the next pulse check. And we'll see, and we'll continue CPR right afterwards. So Erica, you'll actually start CPR right after that next shock, okay? So
Dr.
anyone-
Bischoff, your POCUS shows no pericardial effusion.
Okay.
Okay, and there was no RV dilatation or septal bowing?
No.
Okay,
Okay.
thank you. Can you also check the lungs, make sure that there's no pneumothoraces
Yep.
on both sides? Thank you. Okay, does anyone have any other questions or suggestions for right now?
So your lung sliding is present on both sides.
Okay, excellent.
Perfect, so no tension pneumothorax. So we ruled out all the other things. It seems like this is just a straight STEMI, so we'll treat this as such, okay?
Next pulse check due. 2 minutes since the last pulse
Okay,
check.
so let's charge both those.
First
All right, good
catheter,
CPR.
Charge the other one as well.
We'll swap you out in just a few seconds.
Yep.
Okay, second monitor, charging to 200.
So let's just do a
ready?
pulse and rhythm
Okay.
check. So the patient's still in course VF. So
Okay.
let's do dual sequential defibrillation.
Okay.
Anna, it's on you, okay?
Yep, you do
Okay,
both.
clear. Okay, first shock delivered, second shock delivered.
All right,
Okay,
on the
back on
chest,
chest.
Erica. Good.
Perfect.
Great CPR.
Okay, so we've done dual sequential defibrillation. We're going to continue CPR for another 2 minutes, and then we'll do a quick pulse check at that time. The end-tidal CO2, end-tidal CO2's come up to
Oh, good.
40.
Okay.
So why don't we just do CPR for another minute or so, and then I'll do a quick pulse check, see if we've had improvement, okay? Because I feel like that end-tidal CO2 is quite reassuring.
Walk the bed. Anna, can you walk the bed, please? Oh,
Dave, can you let me know when it's been 1 minute since the defib?
I can do that.
Thanks. All right, and how long has it been since we gave amiodarone 300?
Amiodarone 300 was given 5 minutes ago.
Okay. I think it's still okay for now. Probably has only just gone into his system and taking effect, so.
You don't need to give any light over.
I think that we'll probably just give one or the other.
Okay.
Yeah.
You may take them off.
yeah.
Excellent CPR.
Oh, you know what? When you pause for a moment, I actually feel a pulse. So just.
Okay.
Yeah, I have a pulse. So it looks like the patient's back in normal sinus rhythm. So we have ROSC now. Why don't we start doing post-ROSC care? So, Joanna, do you mind maybe getting an endotracheal tube in because
absolutely.
if we want to get this guy to the cath lab, we'll have to get him intubated.
Sure, that sounds great. Hey, Anna, would you be able to give me some meds for intubation?
Erica, can you also just take a temperature so that we can make sure that he's normothermic?
How about we do 100 of ketamine and 100 of rocuronium?
100 of ketamine and 100 milligrams of rock.
So he's got good pulse. Let's get a full set of vital signs as well. So it looks like his pressure is a bit on the low side with a
Temperature
map of
taken. What's
60.
temperature?
Jeremy, do you mind starting a norepinephrine infusion? We'll start at 5 mics per minute.
Temperature 36.
Not yet,
thank
not
you.
yet. Wait till Cindy's just grabbing the airway stuff. Thank you.
Are there any other medications you'd like to consider?
100 of rock and ketamine.
So Jared's getting norepi. You guys are getting ketamine and rocuronium ready for the intubation. Just let me know when you guys are prepped and ready to go.
Okay.
I think for now, those are the main priorities. Secure the airway, get them ready for the cath lab.
Okay. Sounds good. So you think refractory VFib from a STEMI, cath lab activated. He's got the STEMI meds.
Yeah.
He's on norepinephrine.
Erica, can you just circle back with cardiology and see if they want us to give a second anticoagulant agent? Did they let us know?
Okay, you ready?
Yes, we give ticagrelor.
Ticagrelor. So can you just get ticagrelor?
Put the OG tube in.
What's the dose that they want us to get? 160. Okay, so
All right, Jeff,
so-
we are ready for intubation.
okay.
Dave,
Perfect.
norepi's running at 5 mics a minute.
So let's
Norepi
just
at 5
stabilize the
mics.
patient's blood pressure before we intubate him. I just want to
Okay.
make sure that that map is greater than 65 before we actually
Okay.
push any sedation or paralytics.
Okay. We do a quick timeout before the intubation?
Yeah.
Okay, so we'll plan
Here's
for,
the ticagrelor. 160 of ticagrelor.
Oh, well,
in.
you're going to have to get that through the OG
OG,
tube.
you're
So,
right. She put it in.
Well, I
Oh,
didn't
sorry.
find the OG.
yeah, well, we haven't put the OG in.
Oh,
We'll
okay.
put the OG once we
The
intubate.
ET tube is in, right?
no,
No,
not
no,
yet.
no. She hasn't
Once the
intubated.
ET tube is in,
Once.
we will put the OG
Correct.
tube in, and then we'll give it to Keg.
Okay, so his blood pressure's come up with the norepi, so I'm just going to pass it over to you, Joanna. You
Great.
can leave the intubation.
Okay, so we'll plan for intubation for airway protection. We'll give 100 of ketamine followed by 100 of rocuronium. We'll plan for intubation with the McGrath and an 8.0 tube. We have the iGel that was functioning well as a backup if we need it. Sounds good. Okay, so Erica, if you want to give the ketamine first and then the rocuronium.
Ketamine in.
And Jeremy, can you make sure that BP is cycling every 1 minute?
Rocuronium.
1 to 2 minutes, so
in.
I can just track that.
Yeah, we're
Yeah.
going every minute.
Perfect, thank you.
Okay. Take it. Thank you. All right, and tube. Thank you. Okay, if you want to pull the stylet out.
Okay, style it a little bit out.
All right, we are
Okay, style it all the way out.
23 at the teeth.
Well done.
Cuff this up.
Through the tube, through the cords.
Slick.
You have positive end tidal.
Yes,
We have
do.
positive end tidal. Good job. And can you actually sync an OG as well?
File that
Good.
out there on
Get breast
screen.
sounds both sides.
So the cath lab called and they are ready for the
Would you mind
patient.
just holding my two
So we can
slides?
end this in there. Great job, guys. Good job.
Great.
All right, that's a wrap, everybody. Good job.
That was a prolonged resuscitation of a simulated cardiac arrest due to refractory ventricular fibrillation, or VF. This simulation was performed by me and my real emergency department team, including nurses, respiratory therapists, and emergency physicians that I work with in real life. This case was run in real time in a single take, and nothing was cut out for the sake of brevity. And because of that, mistakes are expected and they're valuable. The goal is to improve together as a team and to demonstrate advanced cardiac life support algorithms and concepts, not to test or judge anyone. Simulations are designed to replicate the real-world stress of managing critically ill and dying patients, which can be pretty intense for both participants and for viewers. This case was designed to demonstrate structured team-based management of refractory VF, highlight decision-making around escalation beyond standard defibrillation, and to reinforce the importance of CPR quality, timing, and coordination during high acuity resuscitations. It's also meant to translate emerging evidence into practical bedside and pre-hospital care, and while protocols and scopes of practice vary by institution and region, the principles shown here reflect current evidence and evolving best practices in cardiac arrest management. If you'd like to learn more about the background of this case, there's a full written breakdown of the background information, guidelines, and supporting evidence available on my website at drjaffu.com/simulation. We'll also be posting a follow-up video in the coming days that includes these details along with highlights from the pre-brief and debrief with the simulation team. This is the first simulated resuscitation video in a series that we hope will help medical teams care for the most critically ill patients. Everyone that you saw in this video volunteered their time and expertise, and we're offering this education freely. So if you found this helpful, I'd really appreciate your support by liking this video, leaving a comment with cases that you'd like to see covered next, and subscribing to the channel. Thanks a lot, and I'll see you in the next one.